Today, our topic is about dental composites. Coming to the contents, it will be discussed under the following headings: introduction, history, definition, indication and contraindication, advantages and disadvantages, classification, composition, polymerization of composites, and conclusion. Coming to the introduction of composites, composite resins are a class of mature and well-established restorative materials which have their own indication in anterior and posterior teeth. Composite is derived from the Latin word componere, meaning put together. AD specification number 27, and dental composites have continued to evolve with the development of smaller particle sizes, better bonding systems, curing refinements, and sealing systems. Although composites are now well accepted in general practice, the complex steps involved have hindered their full success. Composite is defined by Skinners as a three-dimensional combination of two or more chemically different materials with a distinct interface between them. In combination, properties are superior to those of individual components. According to Sturdivant, in materials and science, word composite refers to a solid formed from two or more distinct phases that have been combined to produce properties superior to or intermediate to those of individual constituents. The history of composites have been quite a vast. First half of 20th century, silicates were the only tooth-colored aesthetic materials. Although silicates release fluoride, they are no longer used for permanent teeth because they become severely eroded within few years. Acrylic resins, similar to those used for custom impression trays and dentures, replaced silicates during late 1940s and early 1950s because of their tooth-like appearance, insolubility in oral fluids, and ease of manipulation and low cost. The major drawbacks of these silicate cements were that they had poor color stability, increased polymerization shrinkage, lack of bonding to the tooth structure, large coefficient of thermal expansion. In late 1940s and early 1950s, polymethyl methacrylate replaced silicates. The first polymeric tooth-colored composite was used, which consisted of polymethyl methacrylate powder, methyl methacrylate monomer, benzoyl peroxide, and N,N-dimethyl para-toluene. These materials could be classified as composites. The polymer powder form a dispersed phase and monomer polymerized to form a continuous phase. Polymerization is initiated at room temperature using redox initiator and a combination of benzoyl peroxide and N,N-dimethyl para-toluene. In 1950s, the first polymer metrics incorporating silica fillers were introduced, and this showed increased mechanical properties and good aesthetics. Poor wear resistance clinically was also a problem, but filler particles were easily dislodged. In the year 1955, Michael Buonocore introduced acid etching, and in phosphoric acid etching creates microporosities in enamel and increases the enamel surface area, wettability, and consequently the spread and penetration of resin adhesives. After polymerization of bonding agent, durable attachment to the enamel surface is achieved by micromechanical interlocking. In the year 1962, R.L. Bowen synthesized an acrylated epoxy resin, bis-GMA, or Bowen resin is the name of it, and it is made up of combination of bisphenol A with glycidyl dimethacrylate. High viscosity and therefore limited amount of filler particles could be incorporated in it, and triethylene glycol dimethacrylate was used as a diluent to reduce its viscosity. In 1964, marketing of bis-GMA composites was done. In 1968, development of polymeric coating on fillers was done, and in 1973, UV cured dimethacrylate composite resins were introduced. In the earlier late 1970s, traditional composites or macrofill composites were introduced. They had mechanical properties which are improved. They had improved water sorption. Polymerization shrinkage was also reduced. But the major drawback include that the poor strength, dimensional instability, discoloration, and polymerization shrinkage due to leaching of uncured monomers and poor surface finish. Main advances have occurred in the filler component of the resin system. The filler particle size was reduced from macrofiller to microfillers, and then came hybrid composites, a combination of micro and mini fillers, thus improving the strength and handling properties. With the advent of nano era, the filler particle sizes went down as low as few nanometers, thereby enabling us to have higher filler loading for use in both anterior and posterior region. This is how the evolution of composites have occurred. In 1955, acid etch technique was introduced by Michael Buonocore, and in 1956, bis-GMA was introduced by Dr. Raphael Bowen. The further important in evolution points include in mid 1980s, hybrid composites were introduced, and in 1996, global composites were introduced, and in 1997, packable composites were introduced. What are the applications of dental composites? It mainly involves aesthetic restorative material. It is a direct splinting of for mobile tooth, component of fiber reinforced composites used in fiber reinforced composite post. It is used as a luting agent. It is used for core buildup material. It is used as an epitaficial sealant. It is also used for bonding of orthodontic brackets. The main indications for dental composite involve the class 1 to class 6 cavities, core buildup restorations, sealants and primitive resin restorations, aesthetic enhancements, veneering, and temporary restoration. It is also indicated in case of periodontal splintings, non-carious lesions, enamel hyperplasia, composite inlays, repair of old composite restoration, and patients allergic to metals. The main contraindications include isolation in cases of subgingival area or root surface caries, in patients who have poor oral hygiene or high caries index, and patients who have habits like bruxism, and where operabilities are not that much elaborate. Main advantages of composite include aesthetics, conservation, adhesion. The composites are repairable. It does not undergo tarnish or corrosion. It has low coefficient of thermal conductivity. The main disadvantages involve polymerization shrinkage. It is technique sensitive. Composites have higher coefficient of thermal expansion. They are biocompatible. Staining is a problem, and sometimes it is time consuming and costly. Coming to the main classification of dental composites, according to Skinner's, it is classified into traditional, small particle, microfill composite, and hybrid composite. Based upon filler particle size, it is classified as megafill, macrofill, midifill, minifill, and microfill and nanofill composites. According to Craig, it is classified into type 1 and type 2 composites according to the filler particle size. Type 1 is further classified into class 1 to class 4, and type 2 is classified into class 1 and class 2. Based on the method of curing, it is mainly chemical cure, light cure, and dual cure. Light cure is further classified into UV cured and visible light cured. Based on inorganic filler loading, it is classified into heavy filler material and light filler material. Based on consistency, it is classified into light body, medium body, and heavy body material. According to the mode of dispensing, it is classified as a two-paste system, single paste system, single paste and liquid system, and disposable capsules. The main part of dental composite is its composition. The major component includes resin matrix, coupling agents, inorganic fillers. Other components include the activator initiator system, color stabilizers, inhibitors, optical modifiers, and pigments. Coming to the resin matrix, it is a blend of aromatic and aliphatic dimethacrylate monomers. Initial resin matrix consists of bisphenol GMA and urethane dimethacrylate. Because of high viscosity, TEC-DMA is also added. TEC-DMA, an increase in TEC-DMA increases the polymerization shrinkage. The dimethacrylate monomers also have the advantage of producing extensive cross-linking among the polymer chains. It results in a rigid matrix and highly resistant to softening and degradation by heat. The filler particles. Size of the filler particles depends upon the requirements and needs. To ensure acceptable aesthetics of composites, translucency of filler must be similar to that of tooth structure. The primary purpose of filler particles are to strengthen a composite and reduce the amount of matrix material. The filler loading is 50 to 85% by weight and 30 to 70% by volume. The filler surface area is for 550 to 400 meters square per gram, and refractive index is 1.50 approximately. An increase in filler improves the reinforcement of the matrix resin, resulting in increased hardness, strength, and decreased wear, a reduction in polymerization shrinkage, reduction in thermal expansion and contraction, and also improved workability by increasing viscosity, reduction in wear absorption, softening and staining, and increased radio opacity and diagnostic sensitivity through incorporation of strontium, barium glass, and other heavy metal compounds that absorbs X-rays. The routinely used fillers include quartz, silica. Quartz is extremely hard and very difficult to grind into finer particles. They are used in earlier composites. Silica is used in many forms as fused silica, pure silica, and colloidal silica. Glasses as aluminosilicates and borosilicates are also used. Other filler particles include tricalcium phosphate, zirconium dioxide. The filler provides strength, rigidity, hardness, increase in modulus of elasticity, decrease in coefficient of thermal expansion, and decrease in contraction. Coupling agents are used to bind filler particles to the resin matrix. They also allow more flexible polymer matrix to transfer stresses to the stiffer filler particles. These agents also provide hydraulic stability by preventing water from penetrating along the filler resin interface. A properly applied coupling agent can impart improved physical and mechanical properties and thereby inhibit leaching by preventing water from penetrating along the filler resin interface. Bonding between agents promote addition between filler and resin matrix. The types include organosilines, titanites, and zirconites. What are the functions of coupling agents? It binds the filler particles to the resin matrix. It allows more flexible polymer matrix to transfer stresses to the higher modulus filler particles. It imparts improved physical properties and mechanical properties. It inhibits leaching by preventing water from penetrating along the resin filler interface. The inhibitors include butylated hydroxytoluene. It is added to prevent a spontaneous start of polymerization. The optical modifiers are metal oxides and opacifiers like titanium oxide and aluminum oxide. It has darker shade and opacifiers in thin layers. The activator initiator system, both monomethacrylase and methacrylate monomers polymerize by addition, polymerization mechanism and initiated by free radicals. Free radicals can be generated by chemical activation or by external energy activation. Chemically activated resins are supplied by two-phase system consists of benzoyl peroxide initiator and other alpha aromatic tertiary amine activator. When the amine is combined with benzoyl peroxide, free radicals are released. In light activated composites, it is available as a single phase system and used for photosensitive initiator system and a light source for activation. The difference between chemically cured and light activated composites are that chemically cured composites is polymerization central, curing is in one phase, sets in 45 seconds. It has no time for manipulation. It has no more wastage and it is not properly finished. Whereas in light cured composite, polymerization is peripheral, curing is in increments. It sets only after light activation, plenty of time for manipulation and less wastage, and takes a better finish. Coming to the main composites as such, first coming to the traditional composites or macrofill composites, which was developed in early 1970s. Commonly used filler for these were finely ground amorphous silica and quartz. They have a particle size of 8 to 12 micrometer. They have better hardness compared to that of acrylic resin, and they contain quartz or amorphous silica as fillers. The main disadvantages of traditional composites were that they were difficult to polish, surface roughness was there, staining occurred, and occlusal wear also occurred, and poor aesthetics was a concern. Coming to the next composite, that is small particle composites. It has a mean particle size with a diameter ranging between 0.1 and 10 micrometer. It is more polishable than macrofill composite, but cannot be polished to a high gloss. It provides filler loading that is as high as 77 to 88%, provides high degree of hardness and strength, but it's slightly brittle and has excellent polishability. The microfill composites has an agglomerate of 0.01 to 0.1 micrometer inorganic colloidal silica particles embedded in 5 to 50 micrometer resin filler particles. It is highly polishable aesthetic composite restoration, and it is performed by a pyrolytic process and which results in particle agglomeration into long molecular chains. It has increased viscosity of the monomer. The main advantage is better surface finish, excellent wear resistant. The drawback of these composites that is bond between the composite particle and a clinically cured metal is relatively weak, and hence microfill composites are not generally suitable for use in stress-bearing areas. Coming to the hybrid composites, they were formulated with a mixed filler systems containing both microfine and fine particle fillers. It consists of colloidal silica and ground particles of glasses, contains heavy metals constituting a filler content of approximately 75 to 80% by weight, average particle size of about 0.6 to 1 micrometer. The nanofill composites have a particle size ranging from 0.001 to 0.01 nanometer, optical properties and superior polishability like that of microfill composites. The surface treatment reduces the increase in viscosity when compared to other composites. The filler loading is in range so that the mechanical properties for use in posterior areas and also in stress-bearing areas. The properties of composites are mainly working time and setting time. For chemically cured composites, ADA specification number 27 requires that a working time be no less than 90 seconds. Polymerization shrinkage is an exothermic reaction, and time from start of mix till the time when temperature starts to rise is taken as a working time. The setting time for chemically cured composites ranges from 3 minutes to 5 minutes. For light cured composites, curing is considered to be on demand, and polymerization is initiated when the composite is first exposed to light. Polymerization shrinkage is a main problem with composite, and it occurs when carbon double bonds in the monomers are converted to single bonds during curing. The formation of polymers result in decrease in total volume. Composites with higher filler content like hybrid and fine particle composites shrink less than resins with lesser filler content as in microfill composites. Therefore, polymerization shrinkage should be as low as possible to enhance marginal adaptation and prevention of secondary caries. Thermal properties, fine particle size less than 25 to 38 micrometer or microfine that is 55 to 68 micrometer has high conductivity of inorganic fillers and matrix. Thermal stress are cyclic in nature and marginal fatigue and early bond failure occurs due to percolation. However, composites do not change temperature as fast as tooth structure and this is not a clinical problem. Water sorption is another problem with respect to composites. The fillers absorb water onto the surface when quality of the serine bond is compromised. The diluent monomers added to the resin coupled with the presence of hydroxy groups in bis GMA molecules result in high values of sorption as 1 to 2%. Since sorption can affect longevity of restoration, it has to be controlled. Water sorption is mainly due to material may have a high solubility rate which dissolves and leaves a space into which water can enter. This could be due to incomplete cure of resin. The resin may contain air voids introduced during manipulation. Hydrolytic breakdown of bond between filler and resins occurs. Solubility of composites is another problem. ADS specification requires water sorption should be less than 40 micrometer or milligram per millimeter and solubility to equal to 7.5 micrometer gram per milligram per millimeter. Color stability is of three types. There are three types of discolorations which are seen: marginal, surface discoloration, and bulk discoloration. Marginal discoloration occurs due to improper adaptation of material to margins of the cavity. Surface discoloration occurs due to surface roughness and it's seen with composites with large filler particle size. Therefore, graded polishing process is denoted for reducing surface discoloration. Bulk or deep discoloration is seen with chemically activated composites and it occurs due to chemical degradation of resin and absorption of fluids from the oral cavity. Radio opacity. AD specification number 27 requires that its radio opacity be equivalent to 1 millimeter of aluminum, which is equal to that of dentin. It is vital to evaluate the integrity of restoration radiographically and is provided by fillers of heavy metals like barium, strontium, and zirconium. Coming to the mechanical properties of composite, it has a composite strength of 200 to 300 megapascal. Nanocomposites have strength ranges leading up to 450 megapascal. Hardness, it is proportional to the filler amount. Therefore, hybrid composites have a greater value than microfill composites. Wear resistance, it is dependent on the following factors: fillers, fill and porosity. Fillers, wear resistance is directly proportional to the filler volume and indirectly proportional to the particle size. Whereas porosity, air entrapment during mixing and placement of composite lead to concentration of stresses in the matrix. The tooth position, more posterior the tooth, more the wear of composite. Degree of polymerization, wear resistance is directly proportional to degree of polymerization. Finishing and polishing, uses of carbides and diamonds result in formation of micro cracks and heat generation. The main disadvantages include that heat production must be controlled and expensive. Light curing techniques. The light curing techniques mainly involves soft start polymerization, ramped polymerization, pulse delay curing, and a high intensity curing. The main disadvantages of high intensity curing are short exposure times. This lead to greater shrinkage stresses. High intensity light curing has narrowed wavelength and also heat is a significant problem. Extraoral curing is used for fabrication of indirect composite that is processed in the laboratory. Depth of cure, the depth of light curing composite is 2 to 3 millimeter with a good light source and technique. The degree of conversion, higher the degree of conversion, the better will be the strength and wear resistance. Clinical implications of composite. Packable composites may be easier for clinician to handle. However, their physical properties were not superior to those of conventional or small particle hybrid resin based composites. Coming to the conclusion, composite restorations have a wide options and a range of restorative options. Patients can retain their teeth longer with a more aesthetic appearance. Correct indication, good isolation, and choice of right composite for each situation, and use of good procedure for bonding of dental tissues and proper curing are essential and satisfactory.